and Purkinje fiber. These here, as you can see, this is here the Purkinje fibers, and this here is the bundle of His. This one here is the bundle of His. So the same way the action potential occur in the myocyte, in the muscles of the ventricle, is the same way that how the action potential occur in these, the Purkinje fibers and the bundle of His. Now let's talk about how this occur, how the action potential happen in the myocardium and the bundle of His and Purkinje fibers. Now, in the first phase or phase 0, the first thing that happen in the myocardial action potential is that there's rapid upstroke and depolarization, and this happens because of the voltage gated sodium channels. So the sodium gated channels open, and when these sodium channels open, you have fast and rapid upstroke. You have fast and rapid upstroke. So as you can see here, the first thing that happens, you have the sodium channels open and the sodium will go to the cell. Here you have inside the cell and here you have outside the cell. So the first thing in phase 0, the first thing that happens that this sodium channels open. When this sodium channels open, it will get the sodium from the outside of the cell to the inside of the cell intracellularly. When this sodium increase in the cell, that will lead to action potential, to depolarization. And this will be fast depolarization, increasing the pressure. The pressure will be very high because the sodium channels will cause fast depolarization. Okay, it will cause fast depolarization. Now, after the sodium channel open and the sodium go to the cell, in the cell or inside the cell, what happens next? Phase 1. In phase 1, you have initial repolarization, resting, okay? Repolarization. So this happens because you have inactivation of the voltage-gated sodium channel. Now you have enough sodium inside the cell. So what will happen after that? This sodium channel will close. Inactivation of the voltage-gated sodium channels. Voltage-gated potassium channels begin to open. Then you have the potassium channels open. The potassium channels, when they open, they will get this potassium cation from inside the cell to outside the cell, from intracellularly to extracellular compartment. So this is what happened in phase 1. You have closure of the sodium channels and open of the potassium channels that get this potassium outside of the cell. After that, you have the plateau of the calcium. How this plateau calcium occur? You have influx through the voltage-gated calcium channels, balances the potassium efflux. You have positive ion going out of the cell, which is potassium. Now you need positive ions to get to the cell. So that's why you will have calcium entering to the cell and the calcium voltage-gated channels will open. So the voltage-gated calcium channel will open and it will balance the calcium efflux. E from efflux going out of the cell. So now you have calcium going intracellularly, and you know that if the calcium go intracellularly and the amount of calcium increase in the cell, this will lead to what? To contraction. So the more calcium you have in the cell, the more contraction you have. So now, influx travel, so the calcium influx, when this calcium going to the cell or inside the cell, the increase of the amount in calcium inside the cell will trigger the sarcoplasmic reticulum, which is the site where the calcium is stored. Now you have this one here. The calcium channel balances the potassium and the the calcium itself, the calcium in the cell intracellularly, will trigger the calcium release from the sarcoplasmic reticulum. Now, we talked about this before. We say that the sarcoplasmic reticulum is a site in the cell. So you have here the cell, here's the cell, intracellularly, you have here more calcium. And this is here sarcoplasmic reticulum. In this sarcoplasmic reticulum, you have calcium. This is the storage place in the cell for calcium. This is a storage place for calcium in the cell, which called the sarcoplasmic reticulum. When this amount of calcium increases in the cell, you have more calcium. This will trigger the release of the calcium from this sarcoplasmic reticulum. And so you have more intracellular calcium, and this will lead to contraction, of course. So the calcium itself will trigger the calcium release from the sarcoplasmic reticulum, and the myocyte contracts. Now we have what we need. All of what we talk about is how to make action potential. And by the action potential, we want to have contraction of the muscles. So now we have contraction. What will happen next? We have the sodium in the cell and the potassium out of the cell, the calcium in the cell, and the calcium trigger the sarcoplasmic reticulum to release the calcium, increasing the calcium amount in the cell, and this will lead to contraction. So what will happen next? We finish what we need. Now what will happen? Phase 3. You will have rapid repolarization. Now the muscles need to rest. So you have rapid repolarization. Massive potassium efflux due to the opening of the voltage-gated slow potassium channel and the closure of the voltage-gated calcium channels. Now still this potassium will go out of the cell. This potassium will still go out of the cell, but also the calcium channels will close. We don't need more calcium. The muscle is contracted and finished. No need for more calcium, so the calcium channels will close. So what will happen at the end? Here you have the resting potential. Resting relaxes of the muscles, the myocytes. So resting potential, you have high potassium permeability through the potassium channels. The last thing that happens is that you have this potassium returning to the cell. The potassium at the end will return to the cell. Let's see how. Here you have the potassium going to the cell. You have this one here, the sodium and potassium pump. You have sodium and potassium pump. So the sodium will get out of the cell, and the potassium will be intracellularly. This is at the end of the contraction, which is phase 4. And as we say here, in contrast to the skeletal muscle, now the cardiac muscle, which is the muscle of the heart, work differently from the skeletal muscle, which is like the muscles in our body, and like the bicuspid and tricuspid muscle, the triceps and biceps. So the cardiac muscle is working different from the biceps and triceps. For example, here, the cardiac muscle, how it is different. Now, the cardiac muscle action potential has a plateau. It has a plateau, which is this one here. You have a plateau of the action potential. The maximum, it has a maximal range. So the action potential has a plateau, which is due to the calcium influx. This plateau, the maximal action potential, this is because you have more calcium. So more calcium, it will reach when the calcium influx reach its maximum, you will have the action potential reach its maximal also. So now, potassium efflux also. The myocyte contractions occurs due to calcium-induced calcium release from the sarcoplasmic reticulum. So why the action potential plateaus? Because there's a maximal limit for the calcium entering to the cell and for the potassium getting out of the cell. When this maximal range of these two reach their maximal, the potassium out of the cell and the calcium in the cell reach its maximum point, here you will have the action potential maximized. Okay, and of course, you know that more calcium in the cell will increase the release of the calcium from the sarcoplasmic reticulum. Now, the cardiac nodal cells, which is the SA node and AV node, the sinoatrial node and the atrioventricular node, the cardiac nodal cells spontaneously depolarize during diastole, resulting in automaticity due to the Funny channels. And the Funny channels are the channels responsible for a slow mixed sodium-potassium inward recurrent. Now we will talk about the sodium and the SA node and AV node, how they do their action potential. Now the cardiac myocytes are also electrically coupled to each other by gap junction. You know that the cardiac myocyte, the muscles, here is the myocyte. The myocyte is the muscle cell. You have here the muscle cell and here another myocyte. And of course, you know that between these two cells, you have a gap junctions. So the cardiac myocytes are electrically coupled to each other by the gap junction. So the gap junction, the gap between these two cells, this is what transmits the electrical signal between these myocytes. Now let us talk about the SA node and AV node, which is the pacemaker action potential. Occurs in SA node and AV node. Now in the previous slide, if you notice, we talk about the myocyte. The myocyte, the bundle of His and Purkinje fibers, how they do their action potential. Yes, and we say that in the first stage you have the sodium going to the cell, and then the potassium getting out of the cell, the calcium enter the cell. So calcium increase, you have contraction. If you have calcium increase, the sarcoplasmic calcium also increase releasing of this calcium to the cell. So you have increase in the calcium in the cell, and this will lead to contraction. And after that, you will have potassium going to the cell, inside the cell, and that sodium will get out of the cell. This in summarize. Now, in contrast to this, you have this one, which is SA node and AV node, the sinoatrial node and the atrioventricular node. How the action potential happens in these two. Now, the SA node and AV node action potential, key difference from the ventricular action potential. It is different from the myocyte, the cardiomyocyte action potential, in that it have no phase 1 and 2, and we will see later what is phase 1 and 2 that we talk about. This is here, phase 1 and 2, which is the sodium, the initial repolarization, which is that the potassium going out of the cell, and of course phase 2, which is the sarcoplasmic release of the calcium and so on. So phase 1 and 2 are absent in the SA and AV node action potential. Now, SA node and AV node, as we say, it's key different from the myocyte action potential. In phase 0, what happens first is that you have the upstroke is the opening of the voltage-gated calcium channels. The first thing that happens in the SA node and AV node is that the calcium channels will open. And when the calcium channels open, you'll have this calcium going to the cell. So this calcium will go to inside the cell, from outside to inside the cell. This is the first thing that happened in the AV and SA node. Now, why this is the first thing that happened and not the sodium channels that open first? Why the calcium channels open before sodium channel? The reason is that when you open the calcium channels first, you have a slow action potential. And you know that the SA node, sinoatrial and AV node, want to be late, want more time to fill the ventricles before transmitting this signal to the ventricles, and the ventricles will contract. So the SA node and AV node want this signal to be slow. And if the signal is slow, it will have more time to fill the ventricles. That's why it will start with calcium channels rather than starting by sodium channels. So sodium channels is inactivated غير مفعلة. Sodium channels are inactivated in the SA and AV node action potential. So as you can see here, SA node and AV node, the first phase is upstroke, which is the opening of the voltage-gated calcium channels, which is fast voltage. Sodium channels are inactivated. Because sodium channels are fast and the action potential will happen fastly, so we don't need this action potential to happen in fast way. We need it to transmit in slowly. We need to transmit this signal slowly, so we don't need the sodium channels. So sodium channels are inactivated, and rather than use the sodium channel, we will use calcium channels. So because of the less negative resting voltage of these cells. So that's why the sodium channels are inactivated, because they cause action potential very fast. And this, if we inactivate this sodium channel, this will result in slow conduction velocity that's used by the AV node to prolong the transmission from the atria to the ventricles. Now again, for the ones who don't understand this point, briefly, so what you will have in SA node and AV node, you will have the calcium channel open, you have more calcium in the cells, and you have the sodium channel inactivated, closed. Okay, sodium channels are closed because the sodium channel is very fast and we don't want a fast signal. We want a slow signal, which is caused by the calcium channels, because we want to fill the ventricles first, to fill the ventricles of blood before contraction. That's why we need a slow signal, and if we want slow signal, we will use calcium channels. Okay, this is the point. Now, what's next? What will happen next? Now, phase 1 and 2, we say that it is absent. Why? Because phase 1 and 2 in the cardiac myocyte, phase 1 and 2 here is talking about that the sodium channel is closed. But originally, we have permanent closure of the sodium channels. أصلا بالاس اي نود والاي في نود عندنا مسكرة دائما الصوديوم channels ما بتفتح. Okay, because only we need the calcium channels in the SA node and AV node, so no need for this phase 1, which happens in the myocyte itself. Now we are talking about the nodes. Okay, so phase 1 and 2 are absent. We don't need them. Now phase 3, phase 2, if you want to remember it. Now phase 2 is the plateau of the calcium reflex, calcium influx, voltage-gated calcium, and it is increased in the release of the calcium from the sarcoplasmic reticulum. Now these two are not required, phase 1 and 2, in the SA node and AV node action potential. So what will happen next? Now what we say in phase 0, the calcium channel increase in the cell, okay? Next, what will happen? Inactivation of the calcium channels and increased activation of the potassium channels. So you have increase in the potassium efflux. So what will happen? We have inside the cell a lot of calcium now. We don't need more calcium. We don't need any more calcium. So the channel of the calcium will close. And after that, you will have this potassium in the cell will going out. So the potassium channels will open. The potassium channel will open and they will get this potassium outside of the cell. Here you have outside of the cell. So this potassium will go outside and this calcium channel will close because we have enough calcium in the cell. So this is phase 3. What happens at phase 4, which is the end of action potential in the SA node? Now, in phase 4, you have slow spontaneous diastolic depolarization. We know that the SA node and AV node action potential happens in the diastole because it's need time to fill, and it is, of course, this signal is before the systole, before the contraction of the ventricle. So we know that this AV node, we know that the AV node and SA node action potential happen and the diastole. So you have slow. Why it is slow? Because as we say, it is calcium channel. The calcium channel is slow transmitting, or it causes action potential slowly. So what will happen next? We have enough calcium in the cell, so we will have slow, spontaneous diastolic depolarization. So slow, spontaneous diastolic contraction of the ventricles. The contraction of the ventricle will be slow, will start slowly. It will be delayed, okay? Because we have calcium, as we say, and it is the action potential, the signal, the electrical signal start in diastole, okay? So now we have sodium conductance. You will have now sodium. Okay, we say that the sodium is not from the SA node, and the sodium channels in the SA node is inactivated. Yes? So how we have sodium here in the cell? Actually, this sodium happens from the myocyte. Now, let me make it more clear for you. As we say here, let us talk about this picture here. Now, here you have, let me choose another color. Yes, here you have SA node and AV node, okay? And the action potential between these two is slow because you have calcium channels. And the sodium channels in this one is inactivated. The sodium channels is closed in the SA node and AV node. But in phase 4, of the SA node and AV node, you have sodium in the cell. How does sodium get to the cell? From the activation or from the action potential that happens from the ventricles. If you remember, we said that the myocyte, the first phase or the first thing that happened in the myocyte is that we have the sodium channels open. So, of course, the last phase of the AV node, which is phase 4, the last phase of the SA and AV node, it will be the first phase of the ventricular contraction. Yes? So the SA node and AV node, the last phase of its action potential will be the first phase of the ventricular contraction or the ventricular action potential, which is the transmission of the signal. So after the SA node and AV node make their signal, they will transmit it to the ventricles. The first thing that the ventricles will do when they have this signal, this electrical signal, they will activate the sodium channels. So the phase 4 in SA node, SA node and AV node, phase 4, it will be the first phase or phase 0 in the myocyte, in the myocardium, action potential. That's why, if you read here, in phase 4 here, you have that the phase 4, the last phase of the pacemaker, SA node and AV node, is a slow spontaneous diastolic depolarization happens in the diastole, and it's slow because of the calcium channels. Then you have the sodium conductance increase. The sodium conductance, which is the sodium in the cell, the sodium inside the cell will increase. Okay, the sodium funny, or as we say, the funny channels is that the sodium getting to the cell. So the funny different from the sodium in the phase 0. So it is from the phase 0, as we see here. It's from the phase 0 of the ventricular action potential. So the sodium here is from the phase 0 of ventricular action potential. The ventricles is the same as the myocyte. Yes, so ventricular action potential is the same as the first phase is the sodium channels in the ventricles, which is in the myocyte, the same as the cardiac myocyte. Okay, so accounts for automaticity in SA node and AV node. The slope of phase 4 in SA node determines the heart rate. We know that phase 4 here, This is the slope, الميل. If this slope decrease, okay, or if this slope become like this, you have more heart rate. If this slope become more linear or straight, okay, it will cause decrease in the heart rate. Why? Because if you increase it, you have more action potential. This slope determines سرعة الأكشن بوتنشال. إذا كان الأكشن بوتنشال أسرع عندكم هارت ريت بيكون أسرع وأكثر، لأنه عندك السيجنال اللي بتيجي أسرع فالقلب بالقبض بشكل أسرع. So this slope اللي هو بداية الventricular contraction which is phase 4 بعد ما تنتهي ال SA node وال AV node action potential. The phase 4 is the same as the beginning of the ventricular contraction. فإذا صارت أسرع، okay، صار الأكشن potential أقوى. So we have heart rate more heart rate. القلب بنبض بشكل أقوى. Okay, this what we can read here. That of phase 4, the slope of phase 4 in the SA node determines the heart rate. What could affect this one? The acetylcholine and adenosine decrease the rate of diastolic depolarization, while it will decrease the heart rate. While the catecholamines, we know that the catecholamines, الأدرينالين, will increase the depolarization, بقوي contraction of the heart. Thus, it will increase the heart rate, which is the same as sympathetic stimulation increase the chance of the channels to open, and so you have heart rate increase. بنعرف إنه إذا إحنا فتحنا القنوات للكالسيوم والصوديوم and so on, you will make action potential and depolarization. وإذا عملنا depolarization, you will have more contraction. If you have more contraction, more beating, and so the heart rate, it will increase. Okay? Now this one here, we are talking about the ECG. The ECG. Now, wait a little bit. Yes. Here you have the B wave. Now, B wave, which is here, this one is B wave, is the contraction or the atrial depolarization. Atrial depolarization is the contraction of the atria. So the contraction of the atrium, this one here, is atrium. So the contraction of the atrium will cause B wave. So B wave, when you see it, we will understand that there is atrial contraction. When there's, in cases that there's a disease and you have atrial fibrillation, and atrial fibrillation affect the contractility of the atrium, so what will happen next? You will have no B wave. So in atrial fibrillation, the contraction of the atria is affected, you will have absent B wave. So B wave is the atrial depolarization. The atrial repolarization is masked by the Qrs complex. Now this is the contraction, as we say. This is the contraction of the atria. Okay, you can ask me, where's the relaxation of the atrium? So if you ask me where's the relaxation of the atrium, where's the wave that tell me that there is a relaxation of the atrium, I can tell you that this is masked by the QRS. The QRS complex غطى a relaxation of the atria. Okay, so as you can see here, the atrial repolarization, which is the resting, the relaxation of the atria, is masked by the QRS complex. Okay, so now you have the BR interval, and you know that the BR interval is the interval between the atrial contraction and the ventricular contraction. So here you have the BR interval. Here, this is R, this is a Q, and this is S. So this is like this. You have the first descent is Q. Okay? The first upward, yes, this is the first downward, this is the first This is here the first upward, and this is R. The first upward wave, you will call it R. Now the second downward, it will be S. So the second downward, it will be S. This is the second descend. Okay, this is S. So the first upward will be R. So in case you have an ECG like this, you will call this one R, yes, because there is no Q. A Q is a descent, so this is R, okay? So now, let us move. So BR interval, you have B here, this is B, and R. So between the BR, it is BR interval, which is between the atrial contraction and the ventricular contraction. Now, BR interval is the time from start of atrial depolarization, which is the same as atrial contraction, to the start of ventricular depolarization, which is the same as ventricular contraction. So it is the time from the atrial contraction to the ventricular contraction. This is what we call it the BR. Normally, it should be less than 200 milliseconds. Okay, this interval here should take less than 200 milliseconds to occur. If it took longer than this, we call this one a prolonged BR interval, and it is abnormal, okay? Now, Qrs complex here, Qrs complex, is the ventricular depolarization or the ventricular contraction. So the ventricular contraction is a QRS. Here the QRS, this one, QRS here is the ventricular contraction. The mechanical contraction of the ventricles, and then you have, and this ventricular contraction, normally it should take less than 120 milliseconds. So this one, the QRS complex, hey, this QRS, this all should take that less than 120 milliseconds, okay? So yes, QT interval, you know that the T is the relaxation of the muscles, of the ventricular muscles. So here T, now this one T, is the relaxation of the muscles, of the ventricular muscle. So QT interval is the interval between, from the ventricular contraction till the beginning of the relaxation. QT interval, it's from here. This is a QT interval, as you can see, QT interval. And it is normally, the QT interval is ventricular depolarization, mechanical contraction of the ventricles, to ventricular repolarization. From the depolarization to the repolarization. So from the contraction to the relaxation of the ventricles. This is what we call QT interval. Now the T wave here, you know that the T wave is the ventricular repolarization, which is the ventricular relaxation. And the T wave here, inversion may indicate recent MI. You know that inversion of the T wave, it is abnormal. Now, as you can see here, on the picture here, you can see that T wave is upward. Yes, it's upward wave. If this T wave inverted, أو انعكست لتحت, inverted, this is abnormal and can indicate recent MI. صار عندنا احتشاء في القلب، في عضلة القلب، نوبة قلبية جديد. If you see this one, okay, the inverted T wave. Now, so as we say, inverted T wave means recent MI, myocardial infarction. Inversion may indicate recent MI. Now, the G point is the junction, G from junctions, okay? So G is the junction between the end of the QRS complex and the start of the ST segment. Now we know that the ST segment is this one here. The ST segment is this one, the end of S, this is S, yes, and this is T. Now ST segment is the segment between these two, which is here. This one is the ST segment. This here is the ST segment, and the ST segment, as you can see here, this is the ST segment, yes, and ST segment, the junction between this ST segment and the end of the QRS here, the end of the QRS, which is this point here, and the beginning of the ST segment, we call G, junction, which is the junction between the QRS and the ST segment. Here you have the ST segment, because this is S and this is T. So ST segment, this is here, and the junction, this point, is called G junction, okay, on the ECG. Now, G point, we talk about it. It is the junction between the end of the QRS complex and the start of the ST segment. Now, the ST segment here is isoelectric, ventricles depolarized. Now, the ST segment is between the contraction of the muscles and the relaxation of the muscles. So it's between the contraction of the ventricles and the relaxation of the ventricles. Okay, so you have, it is isoelectric time. It's the isoelectric ventricles depolarize. When after the contraction happens, before the relaxation begin, you will have ST segment. Now, the U wave, what is the U wave? Do you hear of it before? Now, the U wave here is caused by hypokalemia, bradycardia. If you have hypokalemia, which is decrease in the potassium, decrease in the potassium can cause this U wave, as you can see this one here. Now, this is the U wave. U wave happens if you have decrease in the potassium, if you have decrease in the heart rate, bradycardia, you can see this U wave. Now, the speed of conduction for this one, let's see, let us take a look on the other picture. Now, this one here, to understand the speed of conduction. Now, this one here, as you can see, this, as we said earlier, that this is Purkinje Fibers, Purkinje system, and this is a system that can transmit the electrical signal and can make the action potential, as we say, and this system make action potential the same as the myocyte, okay, the 0, 1, 2, 3, 4 phases that we talk about it earlier in the beginning of the lecture today. And also we have the bundle of Hess that we talk about it also. This one here, you have the bundle of Hess. These two can make action potential the same way that the myocyte do it, okay? So unlike the SA node and AV node, it is different, okay? Now you have here the SA node and AV node. Here you have the SA node, the sinoatrial node in the atrium. And you have here the AV node between the atrium and the ventricles. You have here the atrioventricular node, the AV node. And then you have here the right bundle branch. If you listen or if you know that the right bundle branch block or the left bundle branch block, this is here. This is the right bundle branch, and here you have the left bundle branch. Okay, this is one here. This one here is the left bundle branch, and this is the right bundle branch. Okay, so if you have a left bundle branch block and right bundle branch block, this is here the problem. Okay, the transmission of the electrical signal in this branches is the problem. Okay, now you have also something called the vesicle. The vesicle is, you have the left anterior vesicle, you have the left posterior vesicle, and the same on the right and on the left. Okay, so the vesicles is like this one. Here is the vesicle, here is the vesicle, here is the vesicle, the anterior and posterior. You have anterior and posterior. This one is the vesicle, this one is the vesicle, and the same for the other side of the heart. Now we take a look over the system, the conduction system of the heart. Now let's see which one of these is the fastest. We know that the AV node is the slowest, because we know that the AV node should take time, because the AV node need to be delayed, so the ventricles will get fill more. Okay, so the ventricles will have time to fill or to take blood from the atrium. Okay, so yes, this is here, the AV node is the slowest speed of the electrical conduction. So the electrical signal conduction in the AV node is the slowest, الأبطأ. Okay, so now yes, the speed of conduction, the fastest one in conduction is the Purkinje. And you can guess why if you look to the picture in reality, because if you look here, you know that the Purkinje fibers, this is one that transmit the signals to the muscles, yes? And the muscles of the ventricle get to contract in the same time. So this makes sense if I tell you that the Purkinje here, Purkinje system, which is in the muscles, in the muscle itself, in the myocardial muscle, it is the fastest because it's need to spread the action potential or the signal in the same time, so the muscles can contract in the same time, of course. So this is why the Purkinje are the fastest signal conductor among these all. Now the Purkinje fiber is the fastest. After that you have the atria. After you have the Purkinje, you have the atrium, which is the SA node, and after that you have in the signals in the ventricles, and after that you have the slowest one is the AV node, as we say. Now the pacemakers, we say that after the Purkinje, now the pacemakers, as we say, the SA node is faster than the AV node. And how this happened? Now, how the conduction happened in all these pathway? You know that the SA node will give the signal to the AV node. After the AV node have the signal, it will give it to the bundle of His. And after the bundle of His, this bundle of His will transmit the signal to Purkinje fibers. So from the Purkinje fibers, you have the ventricles will contract. So here, you have this one from the SA node to the AV node here, from the AV node to the bundle of His. This one here is the bundle of His, as you know. The bundle of His here, this one. So after bundle of His, it will go to the Purkinje fibers, which is here. The Purkinje fibers at this point. And after the Purkinje, the ventricles will contract. Because once the Purkinje has the signal, it is fast. It will contract, okay? Once it have a signal, because it's fast, it will contract fastly, okay? In the same time. Now, conduction, by the way, we talk about this one, it's the same. That if you have SA node, once the SA node have the signal, or it make the signal, because it is the pacemaker of the heart. So the SA node have a signal, the atria will contract first. Why the atria contract first before the ventricles? Because the atria need to push this blood in it to the ventricles. So that's why the atria contract before the ventricles. And after the atria contract, you have this AV node will conduct the signal to the common bundle, which is the left and right branch. And after that, you will have it will go to the bundle branches, as we say, the common branch, and then the bundle branches, the right and left. After it go to the common, it will go to the right and left, yes? So the bundle branches, and after that to the vesicles that we talk about it, the vesicles like this, and then you have here the Purkinje fibers. After the Purkinje fibers, you'll have the ventricles contract. Now, as we say that the SA node is the pacemaker of the heart. Heart dominance with slow phase of upstroke. We say that it will be slow in order to make the ventricles delay in contraction and to fill the blood in the ventricles. Now, the AV node, as we said, is the slowest one, and it is located in the posterior inferior part of the interatrial septum. The interatrial septum, you know that interatrial septum, which is the septum between the atriums, okay, between two atria. Here you have the left atria, the right atria, and between these two, posterior inferior بالأسفل, posteriorly you have this AV node, okay, the atrioventricular node. Now, blood supply usually for this AV node is from the right coronary artery. Why this information is important? Because if anything happened to this right coronary artery, like a thrombus in it, embolus, anything happens to this right coronary artery, and it is affected, the AV node itself will be affected. So the conduction of the signal from the AV node to the ventricles will be affected. So you could have bradycardia and or bundle branch block, for example, okay? So, or supraventricular tachycardia, anything if this is affected. But properly, you'll have a bradycardia. Now, 100 milliseconds daily delay allows time for the ventricular filling, as we say. As we say that the AV is slowest and it have 100 millisecond delay in the conduction of the signal, so this will allow time for the ventricular filling. Now we talk about this one, we finished this one. So actually we finished our class for today. I hope that you understand. We will continue tomorrow inshallah, and I think tomorrow we will finish the physiology part of the cardiovascular system, so we can start in the pathology. So thank you, see you the next time.